Hello everyone, this is Dr. Minist again. Let us now discuss about differentiation syndrome in AML. So suppose you get a patient of AML, you start him on treatment, and after 5 days, patient develops severe breathlessness, chest pain, and fever. So one of the possibilities is differentiation syndrome. What is it? It's also called as retinoic acid syndrome, and it's a life-threatening complication in AML. Okay, and this is associated with the differentiating agents like ATRA and ATO, right? All transretinoic acid and arsenic trioxide, which we use in acute promyelocytic leukemia. Okay, so what happens here is because of this differentiating agents, there is a rapid maturation of leukemic promyelocytes. Now these leukemic promyelocytes will convert into neutrophils, and these neutrophils will start releasing cytokines, leading to cytokine storm. So pro-inflammatory cytokines like interleukin 6, TNF alpha, VGF leads to systemic inflammation, capillary leak, and endothelial dysfunction, which will lead to end organ effects like there will be fluid leakage, causes pulmonary, cardiac, and renal complications. So coming to the clinical features, systemic features like fever, malaise, and weight gain will be there. Respiratory, dyspnea, hypoxemia, pulmonary infiltrates, and pleural effusion. Cardiovascular, tachycardia, hypotension, pericardial effusion. Renal, AKI. Another like edema and MODS, multi-organ dysfunction in severe cases can be seen. Now coming to the risk factors, high leukemic burden if the patient is having, rapid initiation of differentiating agents, and comorbidities if the patient is already having like renal or cardiac dysfunction, and delay in steroid prophylaxis or the treatment. Coming to the diagnosis, the clinical diagnosis based on the symptoms patient if develops after the therapy is started, and exclusion, we have to rule out other causes which can present with similar complaints like infections, leukostasis, or other causes. Okay, and then X-ray and CT will show bilateral pulmonary infiltrates and pleural effusion. Now coming to the management, for prophylaxis, we have to start the patient on steroids, that is prednisolone 0.5 to 1 mg per kg per day, or dexamethasone 100 mg BD, and monitor the clinical and laboratory parameters. For the treatment, steroid dexamethasone 100 mg IV every 12 hours for 3 to 5 days has to be given. With that, supportive care like oxygen, diuretics, and broad spectrum antibiotics has to be given. In the severe cases, we have to temporarily discontinue the treatment, and you have to, for leukocytosis, you have to give cytoreduction with hydroxyurea or leukophoresis. And dose adjustment of the differentiating agents has to be done if needed. Next is prognosis. Mild to moderate cases, good prognosis with prompt steroid therapy, but in severe cases, there is increased mortality due to respiratory failure or the organ dysfunction. Now, key points: differentiation syndrome is a medical emergency. Early recognition and steroid therapy is crucial, and multidisciplinary management improves the outcome. Thank you.